Great. Well, thank you so much to our four outstanding speakers for really wonderful talks on a very important and difficult topic. I thought the talks were all wonderful. So we are pleased now to kick off the panel discussion here. So I'd like the audience to go ahead and put your questions in the chat, and we can pose them to our speakers as they come in. We do have a question to start. Maybe I can start with this one as people are getting their questions into the chat. The first question says, until now, non-invasive diagnosis is mostly made by echo parameters, concentrating on LV stiffness and natriuretic peptides. Is that still the way to go? Because some patients have low natriuretic peptides and discordant echo parameters, which make the diagnosis difficult. What do you think about LA strain, for example, in terms of diagnosing Hfpef? Maybe Dr. Sharma, would you like to take this question?
Sure, I'm happy to. Hopefully you can hear me okay. So it's a great question and appreciate the audience member for asking it. This is really actually one of the greatest challenges that we have in the clinic setting is the patient who doesn't always fit the classic definition or for Hfpef. I shared a couple of the scoring algorithms that I think are useful, both from the Mayo Clinic and from the recent ESC group that published the Hfpef guidelines. But as you can see, we are increasingly seeing obese patients with Hfpef who have low BNP or NT-proBNP levels, and this is an incredibly challenging population. It's a majority of what we see in Baltimore, certainly. So yes, I think left atrial strain can be helpful, but increasingly exercise echo testing to look at diastolic parameters, as well as what we consider gold standard, which is right heart catheterization with exercise, I think is increasingly helpful to identify the Hfpef syndrome, particularly in your obese population where physical exam can be limiting.
Yeah, let me just add a couple of comments here. One, there are published formula for adjusting BNP thresholds for body mass index, and I found that to be useful, particularly in this obese Hfpef population. Might be considered. Secondly, I think Hfpef still largely remains a clinical diagnosis. And in trials such as the CardioMEMS Champion study, where we enrolled patients based primarily on a clinical diagnosis of Hfpef, patients that had demonstrated one or more, clear episodes of congestion, congestive heart failure with a normal or preserved ejection fraction, by implantable hemodynamic monitoring, we confirmed the diagnosis in all of those patients. So, I think that imaging technologies, exercise hemodynamics, these are, great additions to our armamentarium for the diagnosis. But still, this is largely a clinical diagnosis.
Thank you. Actually, I'd like to ask a follow-up question to our speakers based on that first question. So we talked about low natriuretic peptides and discrepant echo parameters. What about the other extreme? I'm a nephrologist. Most of my patients have very high natriuretic peptides. All of them have high baseline levels of echocardiographic abnormalities, high symptomology. How do you diagnose Hfpef in those patients? Do all of my patients have Hfpef?
So I would say it's an equally challenging predicament, particularly when the kidney disease is worsening. What is driving the volume overload state? Is it actually myocardial derangements and stiffening of the heart? Is it actually the kidney dysfunction, or a combination of both? I think that certainly, as Dr. Abraham said, this is ultimately a clinical diagnosis. If the patient's been in hospital with classic heart failure symptoms, orthopnea, P&D, bendopnea, abdominal distension, often at that time when their kidneys are going off, the right-sided symptoms are really becoming more prominent. They're being diuresed. We still call it the heart failure syndrome. I generally will call it a heart failure syndrome up until probably stage 4 CKD. And once they're on dialysis, at that point, a lot of the heart failure therapies are now coming out of the picture, and it's really about dialysis for volume management, and that becomes a very gray zone about what do you call the syndrome. But it is complicated. I think the volume assessment, though, is far more clear than on the opposite end that we just talked about.
Great, thank you. Dr. Pandey, do you have any?
Yeah, as Dr. Abraham mentioned, clinical judgment is most important probably because many a time there are fallacies of NT-proBNP as mentioned by previous speakers. So clinical judgment as well as the examination finding, many of the heart failure symptom and signs, it may not be differentiated clinically unless we do an echocardiography. So we should give more importance to the clinical assessment and treat accordingly. The improvement of symptom should also be a very important priority.
I have a question for the panel. Going back to the low BNP question, of course, obesity and others can, exacerbate or is associated with that. But most of the emerging clinical trials have used BNP as an inclusion criteria. And that has allowed many of the indications for Hfpef. That being said, the FDA indications do not include those parameters in their indication package insert or recommendation. Is there any concern about indication creep in that sense? Are we actually giving a lot of medicine to which we don't have a lot of clinical trial basis on?
Yeah, Wilson, I think it's a fabulous point that you make by virtue of asking this question. As a clinical trialist, I think having clear indication statements that reflect the population of patients that were included in clinical trials that establish an indication for a particular therapy, really is very important. Otherwise, you do get that indication creep into populations where we know less about the potential safety and efficacy of these therapies.
Yeah, so I think it will be a good question for Dr. Sato as well. Right now, obviously, you're taking care of a lot of diabetes patients, and this is a drug that at least originally indicated for diabetes. Who do you put them in? Do you put them on everybody, or with the strong data suggesting that it could be a preventive medication?
Well, sure. Well, actually, I think this is one of the great contributions of diabetology to general medicine, especially cardiology. Getting serendipity finding. Everyone was present when the empiric outcome was presented, and everybody was really struck by the enormous reduction in heart failure events, which was actually not planned for that trial. It was really a secondary outcome at that time. But of course, there is some disconnect between the efficacy of the SGLT2 inhibitors in lowering blood glucose as compared to preventing cardiorenal endpoints. In fact, if you go to a GFR of around 50, the glucose lowering efficacy becomes more or less minimal. So this is always the problem. Of course, we want to keep the drugs in patients as indicated, but in order to achieve glycemic targets, you need combinations with other drugs being safe for use in cardiovascular patients, and that includes primarily GLP-1 receptor agonists, but also DPP-4 inhibitors, at least those who are proven not to harm or not to increase heart failure events like saxagliptin, perhaps also alogliptin. So there are options, but usually you need to do more, not just to focus on the prevention of cardiorenal events, but still, especially in the younger group, and I think I showed you that especially the younger groups are also at very high risk for developing cardiorenal outcomes early. And in those people, we still want to prevent microvascular complications. And there is still no doubt that by achieving targets, meaning at least below 7% A1C, we will reduce especially retinopathy, but also renal complications, including microalbuminuria. And so this is still something we need to do. But at the end, I also would like to say we gained so much from cardiology in diabetology. So I'm one of those people really looking for the benefit of this interdisciplinary cooperation between especially cardiologists and diabetologists and endocrinologists. But now with the topic we are dealing today, also with nephrologists.
Yeah, I think you hit the nail on the head here with this need for multidisciplinary collaboration. You know, for me as a cardiologist, it's easy to start an SGLT2 inhibitor in my non-diabetic heart failure patient. It gets much more complicated in these patients who have longstanding diabetes or already on maybe multiple oral, glycemic or hypoglycemic agents and or insulin. And so, I really appreciate the help from our diabetologists and nephrologists and, sometimes the primary care physician who plays a key role in orchestrating this care as well.
Do any of you have examples of successful multidisciplinary care models at your respective centers?
Yeah, I would say, at our center at least, not formally so, but more informally. There are combined heart and diabetes centers around the world that I think have, developed very structured programs and interactions to do this. At Ohio State University, it's informal, but highly collaborative and seems to work well for us or for most of our patients.
I might mention that we actually started out early in putting up a registry for all patients getting admitted to our hospital for a myocardial infarction. And on this occasion, we detected so many undiagnosed people with diabetes in those patients admitted from acute myocardial infarction. And then we started a project where we followed all those people over the next 5 years or so. And by really working on this interdisciplinary interface, we learned so much, we gained so much from both sides of the same coin. And of course, you all remember the saying, diabetes is an equivalent of coronary artery disease. It's not totally true. It's always a question of comorbidities and risk factors, but it's a good concept for really having a strong foundation for this joint therapy.
Talking about that collaboration, Dr. Zanat is not here, but he presented some really interesting data on Hfpef with renal outcomes. So maybe I'll ask the nephrologist here in the room to kind of comment a little bit on what you think of the findings.
Am I the nephrologist in the room? I'm looking around.
Yeah.
Yes,
so,
I mean,
being a cardiologist, I can't hold myself to ask one very important question to Dr. Abraham. We have seen this condition, heart failure with reserve ejection fraction, is actually very high mortality situation. 5-year mortality can be as high as 50%. And you showed very new devices, cardiac contractility modulation and all, but none of the trials actually they tried to show mortality benefit. Rather, they are more focused on reducing the heart failure hospitalization as well as symptomatic improvement of the patient. So what do you feel? Are they effective in reducing the mortality? If so, then why they are not going for mortality reduction trials?
Well, I can comment on that latter question. Nisha, I don't know if you want to take on the, Wilson's initial question, but, certainly I think, in device development in particular, for many practical reasons, sample sizes tend to be smaller. And so it's more difficult to power these studies to mortality as a singular endpoint. So we tend to look at composites that might include mortality, but focus more on morbidity, such as heart failure hospitalization, and also on patient symptoms.
great. Yeah, and I can tackle Wilson's question about the data that Dr. Zanad presented and CKD patients. I really liked the framework that he set up in terms of not thinking about these as two separate diseases, but one common parallel pathophysiology, which ties these two conditions so closely together. A lot of the same mechanisms are affecting both the heart and the kidney. In terms of thinking about the therapies, I think it's an exciting time to think about therapies and how they can preserve kidney function. I think certainly there's more data that needs to be generated in these therapies and looking at primary kidney endpoints. The points about which endpoints to use is really important here. And nephrology as this field has evolved a lot in terms of thinking about kidney endpoints that are meaningful. And so, traditionally, we really focused on end-stage kidney failure, when a patient needs dialysis or a kidney transplant. However, I'm really impressed by the eGFR slope analyses as an outcome, because for a patient, you don't want to wait until they have kidney failure. We need to be intervening early, and those are short or intermediate term outcomes that are very patient-centered, and I think more in line with the approach that nephrology is taking today, which is early interventions. In my studies, I tend to use the 40% eGFR decline. I think that's the one that has the best evidence to date. And other unique considerations that need to be addressed in these studies looking at kidney outcomes is certainly the risk of AKI, which is, and how to distinguish AKI from normal hemodynamic physiologic decline in eGFR, which is usually transient that we've seen with SGLT2 inhibitors, for example, but actually protective in the long term. So I think there's a lot more that we have to understand about renal physiology as we do more studies of these therapies.
So maybe I'll ask Dr. Sharma about this question. Why would at least the analysis for eGFR protection better in Hfpef than Hfpef? Seems like that was also what Dr. Zanad was presenting.
Yeah, that's a great question. I don't know that I have the answer to it. It's a pretty tough one, but I think that the kidney and Hfpef relationship is probably even less understood than we have in Hfref, and I think it's mostly driven by the many more comorbidities, perhaps in the Hfpef population. But I'm optimistic that with the Fine Arts trial and other trials coming up with newer agents, that we might be able to kind of find therapies that really target that very key population that has concomitant CKD and may derive benefit.
So Bill, you know that I'm going to ask you about intra-atrial septal device because you skillfully did not actually discuss your results there. So what do you think of the results of reduced LAP2?
Yeah, well, I would start by pointing out that I think the reduced LAP HF2 investigators enrolled a very unique group of patients. Event rates were very low. The annualized mortality rate, cardiovascular mortality rate, was less than 1%. When have we seen a 72-year-old Hfpef population with such a low cardiovascular mortality rate? The rates of heart failure hospitalization were, likewise very, very low. And by virtue of that alone, the trial might have been, doomed to neutrality as it turned out to be. So, there is another ongoing pivotal trial called the Relieve HF study, which is studying a broader heart failure population, inclusive of any LV ejection fraction and with no requirement for exercise hemodynamics. There's another trial, the Frost HF trial, which will be launched sometime in the next few months. Another pivotal trial of a different interatrial shunt device, and there are no fewer than 4 or 5 other approaches to interatrial shunting that are under investigation in earlier stages. I think it's a really exciting field. There's promise to it. I don't think that reduced LAPHF2 represents, sort of a class effect or what we might expect from other studies. And so we've got to get these other trials done to really, discover what the safety and potential effectiveness of intraatrial shunting for heart failure might actually be.
Thank you. I have a question for Dr. Standel, actually, from the audience. It's a question about a dose-related effect with SGLT2 inhibitors. The question is, if we give a Hfpef patient, diabetic or not, EMPA 25, does the patient actually get more benefits beyond 10 milligrams? You know, is there a dose-related benefit to these medications?
Well, of course, most of the trials have studied 2 different or even 3 different doses. And at the end, the results were all lumped together because there were no difference between the various doses used in those trials. So I think it's more a link with the background comorbidity, the baseline GFR, which are very important. And as pointed out earlier, the lower the GFR, the greater the benefit in terms also of renal endpoints, but also including heart failure endpoints. So it's more this type of thing. Of course, there have been attempts to correlate glucose lowering achieved in the trials with the benefit. And of course, this limits the situation that the differences in the trials with SGLT2 inhibitors were around 0.3 hemoglobin A1C per percent. So this is minimal. And in those meta-analyses, there was no benefit seen with SGLT2 inhibitors. In contrast, however, with GLP-1 receptor agonists, where you usually get a difference of around 1% A1C lowering in those trials. And this clearly correlates highly significantly with the MACE benefit. I'm not talking about the renal endpoints here, but the MACE benefit, that's very clearly this connection. So it's still out there in my thinking. It makes a lot of sense that we go to reasonable glycemic control in those patients, but we shouldn't overstate the issue. It's really this interface between lowering glucose, but also doing multifactorial risk therapy. And this includes, of course, prevention of cardiorenal endpoints with proven drugs like SGLT2 inhibitors, but also the GLP-1 receptor agonists are quite effective in reducing renal endpoints.
So there's one chat.
I would like to ask one question to Dr. Sharma. I was intrigued by your genotyping studies. And my interest in metabolic terms is insulin sensitivity or insulin resistance. Did you come across activated or deactivated genes in relation to insulin sensitivity, perhaps also adiponectin pathway, which is another thing? Actually, BMP releases adiponectin. So there's some kind of circle in there. It would be of interest, and especially if there are differences between Hfpef and Hfref patients.
Yeah, thank you for the question. So in the plots that I shared, and I went through it very, very quickly in an 8-minute talk, but we picked the top sort of 20 pathways that were differentially either highly expressed or underexpressed in Hfpef. Surprisingly, diabetes and insulin resistance in itself did not pop up in that top pathway, but if you look at the complete analysis that we published in Circulation, we do see a number of pathways implicated in diabetes that are overexpressed in Hfpef. One thing that is clear is that metabolic pathways such as oxidative phosphorylation centric are really seeming to be distinguished in PEF versus REF. And we are right now performing tissue metabolomics to really understand some of those differences comparing to Hfref and controls. So I think we have a lot to learn there. And increasingly, this is looking like a multi-morbid metabolic type picture in the Hfpef population right now.
Thank you.
Well, wonderful. I think we are now at the top of the hour and out of time. That went by too fast. I think we all have a lot of questions. This is a very exciting discussion. And I want to thank our speakers again. I want to thank my co-moderators, Dr. Tang and Dr. Pandey, for a really outstanding session today. And thank you for attending. Take care.
Thank you. Bye-bye.
Thank you very much.
Thank you.
It was a great pleasure.
Thank you.